Well, hello everyone. This is Dr. Amig, your friendly rheumatologist. Well, first of all, thank you so much for being here, for being listening to another episode of Rheumatology 101. Today, I'm going to talk about sarcoidosis. It's an inflammatory condition. It's actually pretty rare, and we're going to learn how what it is, how it's diagnosed, and how it can present and how we can treat it. But before I do this, I want to say and to wish everyone a happy 2024. I wish you the best for this year. I wish you most of all love, wealth, and most importantly, health. Okay? So happy new year. I hope you have the best health you have ever experienced. And I hope, and I'm very, very grateful to be on this with you on this journey. All right, so without further ado, what is sarcoidosis? Sarcoidosis. So it's actually an inflammatory condition that's quite rare, and basically that can affect all of the organs. We're going to see this later, and when we look at it, it's actually granuloma, and you're gonna understand how it works very soon. So. And then it can affect all of the organs, and it can be really bothersome, or you don't necessarily realize that you have this, okay? Then we're gonna see how we diagnose it and how we can treat it. So to understand, so first of all, we don't actually really know why sarcoidosis, what sarcoidosis really is. What we know is when if you had a bump on your skin, if you have involvement of your lungs, or if you have involvement of your spleen or your liver, if you do a biopsy, what we find is something called granuloma. And what you have to understand is that when we are looking at this granuloma, so you imagine, so the way I explain it, and it might not be exactly this, but it's a very good way to understand it. So when you have an infection, when you have a foreign body, so let's say you inhale something that you shouldn't inhale, right? One of the way that your body takes care of that is that it's going to form a granuloma around that foreign body or around this infection. So for example, you have tuberculosis. One of the way that we stop tuberculosis from going everywhere in our body is basically the body goes and forms a granuloma. And so if we imagine that this is the infection or the foreign body, our own cells are going to come, our immune cell, and are going to put around it and basically put it in a ball, which is called a granuloma, and because it looks granuloma, and basically by doing this, it stops it from going any other place. So it's actually super cool when you think about it. It's like you have this infection and you're putting it around, so then like the rest, all of those other cells are ours, and so it doesn't do anything. And so, for example, if you were to have been in contact with tuberculosis, tuberculosis is something that likes the air, like so oxygen. So usually it has a tendency to be in the upper airway. And so you can actually see on an X-ray the granuloma with just one round thing on your lungs, right? It's really cool if you think about it. It's really a good way for your immune system to say, hey, hold on, stop, stay there. We don't want you to go anywhere else. So really smart. In sarcoidosis, we see this granuloma everywhere, and we can't really see any reason for it to happen. So it's almost like there is this formation of this granuloma, but we can't really see any foreign bodies. We can't see any infection. And so it is possible that an infection triggers that response, but we don't actually know if that's the case. It is more common in African American, and it is more common in Scandinavian. So I would say that Scandinavian, so north of Europe, and African American are more likely to have sarcoidosis. In terms of how it presents, so this is where it's also very cool. you may have zero symptom whatsoever, like none. And so sometimes we're gonna see some involvement on your chest. So imagine, like, for example, you need a pre-op and you need a chest X-ray because you're gonna get, I don't know, maybe a replacement of a knee, or like some sort of X-ray. And you're going to have some sort of surgery. We do a chest X-ray, and then we may see things that look like possibly this is sarcoidosis, because we may see some involvement of your lymph nodes and some lung nodules. And if we were to do like a biopsy, which most likely we would recommend, just because we want to make sure, unless you have other manifestation, we want to make sure that that's what it is. Then we see this granuloma, and we're like, well, you have zero symptom whatsoever. It's okay, we're just going to photo this. So it can be zero symptom whatsoever. And on the other hand, it can actually go all the way to severe symptom, heart condition, neurological condition, and so on. In terms of the manifestation that are the most common, I would say that the skin lesion is pretty common. So that's basically what we call erythema nodosum. So it's an inflammation of your skin that looks like a bump and are very painful, usually of the lower extremities. If you have them, you know, because they are painful and they are tender and they are red, and they just happen, and you haven't had any trauma, and so there's no reason to develop those nodules. So that can happen. You can also develop inflammation of the eyes, usually if that's something that your ophthalmologist would find. So that's called uveitis. And so they are very good at asking the help of rheumatologists for diagnosis. And then you can have like involvement of your liver, of your spleen. And then, of course, I had mentioned this earlier, your chest is really something that can be involved, because you can have involvement of your lymph nodes inside the chest, as well as your lung, the parenchyma, so the tissue of your lungs. So those are like the most common presentations. So lungs, lymph nodes, the eye, the skin, those are like really common. You can also have involvement of the joint, and so you can have joint pain, and that's usually an inflammatory, so worse in the morning, associated with more than 30 minutes of morning stiffness, and there can be some swelling of the joints. That's inflammatory arthritis. And for some unknown reason, we don't really know why, sarcoidosis loves the ankles. So if you have inflammation, like inflammatory arthritis of the ankle, that is something that, like, personally, my antenna on top of my rheumatology head are like beep, beep, beep. Could this be sarcoidosis? Okay, especially if you're African American or Scandinavian descent. So those are like the most common presentation. In the spleen or like the liver, you can have like some liver function that are like abnormal. So that's something that we can see. Other than this, you can actually have, so then that's less common, but that's, more dangerous. You can have involvement of your heart, as well as involvement of the nerves, and involvement of your kidneys, and hypercalcemia, which can be really a problem. And the reason I'm putting this letter is that even though heart involvement in sarcoidosis is uncommon, we usually recommend to do at least an EKG, so checking if you have any conduction abnormality in your heart. Because if you think about it, if those granuloma go, and they can go into in your heart, I mean, in a way, it would be okay as long as they don't cause any issue. But if they go where there is the electric current, then they can cause conduction issues, and that is a problem. And you may need a pacemaker in those cases. So this is important because it's super rare. It's not common. But if it does happen, then we have things that we can do to prevent issues from this. And so a good way to, well, first of all, definitely we would recommend an EKG to just make sure you have no conduction abnormality. So conduction, because that's like electric current. And if we like, or if you have any like syncopal episode, if you have any sort of symptoms that would make us think that there is a cardiac involvement, then we do recommend to check for inflammation of the heart with a cardiac MRI, or some people I think do PET scan of the heart. So yeah, even though it's not common, we do recommend it, okay? We also check to see how your level of vitamin D and calcium are, and of course, like kidney function, liver function, and so on. So, right, so let's say you have never had any symptoms and we find that there is something that could look like sarcoidosis in your lungs on a pre-op chest x-ray, then just expect that we're going to do a really thorough physical exam. We're going to ask you tons of questions. And then the next step will be to do an EKG and check if you have any sort of abnormality of your kidney, of your liver, and so on, okay? And your vitamin D and calcium. Now, how do we diagnose sarcoidosis? So it's actually not easy, but it's not too complicated. Why do I say this? So you have to remember, so this is really important, that number one, there's always like, how do we diagnose something for research purposes? Because we want to make sure that everyone that's in the research studies are similar in a way, so that we really look at what's going on if we're doing like a new treatment or something. So, you know, we know that that's the treatment, that's the only variable that changes for people. And then there is the how we diagnose for treatment, right? So in general, the way that we diagnose sarcoidosis is that there is a clinical or radiological presentation. So for example, if you have lymph nodes that are involved and it looks like you have bigger lymph nodes in your chest, what we call the adenopathy, Keeler adenopathy, or you have like lungs involvement, and then you have the erythema nodosum, when I was saying like, you know, the skin bump that I was mentioning earlier. If you have that plus joint pain, like that's inflammatory of the ankle, if you have that, really, like, I almost want to say that you probably don't need a biopsy. However, I would say that if you really want to make sure, we would do a biopsy, and that the biopsy of those lymph nodes or of the lung, if you have lung involvement, then they would show us what we call non-necrotizing granuloma. So the granuloma, we would see that. And the reason the non-necrotizing is so important is that if it is necrotizing, it's telling us something else. So that is important. So non-necrotizing granulomas plus the history, plus maybe some radiologic findings, that is pretty much, we can say, okay, this looks like sarcoidosis. We also have levels of ACE level, angiotensin conversion, and that, you know, we used to think that it was a lot more helpful than it actually is. Some people do follow them to see the activities. I don't know that we cannot make a diagnosis just based on this level. And so I think that's, you know, that's kind of like how we diagnose sarcoidosis. So basically, the way that you present is consistent, and then we find histological evidence of non-necrotizing granuloma. And then in terms of treatment, if you have zero symptom and you have no complications from sarcoidosis, we just look at you and we're like, yeah, you don't have to worry, okay? And then we follow you in the sense of like, we want to make sure, you know, at least once a year that we double check everything. We maybe do some blood work, and, you know, we just want to make sure that this is going into the right direction or it stays exactly the same, you know. If you have mild symptoms, so for example, let's say you have joint pain due to sarcoidosis, we usually treat the same way that we would treat an inflammatory arthritis. So we're going to maybe treat you with plaquenil, hydroxychloroquine, which is not immunosuppressive. Then we could go to methotrexate, which you've heard me talk for rheumatoid arthritis, for example, and so on. And then we can actually also do biologic agents such as TNF inhibitor, because there are some TNF inhibitor that can really, so like such as Humira, adalimumab, infliximab, those can really help remove those granuloma. And so that really can help. So if you have, involvement that are causing more issues and it's not responding to the methotrexate, then that's when we are going into that route. And then there are other treatment as well. So, like if you're really thinking about it, it's like it's an inflammatory response. Either it's very minimal, we don't have to worry about this and we just follow, or it can be all the way to really severe, in which case we treat with even up to biologic agent and not just, methotrexate. We can, do quite a bit of things. I forgot to mention that we can also give you steroids, prednisone, and that's almost like it's considered the first line. The truth though is that unless you only need a little bit of prednisone here and there, we usually, as a rheumatologist, I try to have my patients not on steroids because steroids have a ton of complication. We have a lot of very good other treatments. But that gives you an idea, like if you actually really listen, you're like, oh, wow, it almost sounds like the treatment of rheumatoid arthritis or the treatment of psoriatic arthritis and so on. And so, yeah, in a way it is because it's an inflammatory process. So this is really just the overview. I hope this is helpful for you. It's a fairly rare condition, and I just wanted to share this because I had a patient and like he had not had any explanation of what he had, and I thought, oh, okay, let's discuss this. Thank you so much for listening and tuning in. I will see you next time, and you can also follow the other. I have a podcast called Unabridged MD, and we talk about health. It's not just rheumatology, just health in general, because it's really important. I think there's a lot of value as well there. Have a wonderful day, and Happy New Year again. Take care. Bye-bye.